بسم الله الرحمن الرحيم. نبدأ الآن السيشن الأولى اليوم عن كيس برزنتيشن. في البداية طبعا أشكر اللجنة المنظمة على رأسهم الأستاذ الدكتور طارق صفوت، الأستاذ الدكتور عادل الخطاب، وأخي الحبيب الأستاذ الدكتور جمال عجمي على التنظيم الرائع في الحقيقة. وفي حاجة كويسة جدا إن ورك شوب منفصلة عن البرزنتيشن دي أفضل كتير في التنظيم ده. نبدأ أول كيس برزنتيشن من دكتور نزار رفعت. اتفضل دكتور نزار. دكتور نزار دايما احنا متعودين يجيب لنا حالات كويسة باستمرار، ودايما يقدم كيس برزنتيشنز كتير قوي. اتفضل. عليكم السلام ورحمة الله وبركاته. ماشي. دوس على الزرار كده يا دكتور نزار. دكتور مين؟
دكتور عمر. أنا يا عمر الحاج من السودان.
عمر الحاج. عمر الحاج.
دوس على الزرار. اوكي. احنا بينا تايمر يا راجل 15 دقيقة. زعلني منك. السلام عليكم.
عليكم السلام.
هي مش كيس برزنتيشن واحده، هي شويه بروبلم سولفنج كده وحاجات كلينيكال من اللي اتعلمناها من حضراتكم. اول بروبلم هي 64-year-old female 2 months ago developed left calf pain. على فكره الجزء الاول من البرزنتيشن او الجزء الاول ده هيستوري اتاخد منها، يعني لما جت ايه اللي حصل معاكي ده انا كنت كده يعني. 2 months ago developed left calf pain, no fever, no swelling. For last several days she started to have shortness of breath, mainly exertional and progressive, and diffuse chest pain. No wheeze, no cough, no flu, no fever, just left calf pain. And after several days, and for the last several days she started to develop exertional shortness of breath. Based on that, a respectable doctor referred her to ICU. Past history of concern: 5 years ago she had left side DVT and received the Marivan for a year. We don't know why for a year. And at that time there was no clear risk factor for venous thromboembolism. If we are responsible for this patient at that time, what investigation we will do? Chest X-ray, echo, lower limb Doppler, D-dimer, routine labs like CBC, renal function, arterial blood gas, all of the above. We will show what actually happened. It is not, we will not choose some choice or so, just brainstorming. But what happened is that chest X-ray revealed nothing of diagnostic importance. Echo with a normal ejection fraction, mild pulmonary hypertension with pulmonary R systolic pressure 4.3. Lower limb Doppler was done and was negative. D-dimer was negative. CBC, hemoglobin 13, white blood cell 14,000. Renal function test normal. ABG at that point result not available for me. في حاجات كانت جايبها معاها وحاجات ما كانتش جايباها، من ضمنهم الاي بي جي ما كانتش جايبه معاها اي بي جي. ده الدي دايمر بتاعها كانت جايباه وكان نيجاتيف. ده الدوبلر اللي هي كانت عاملاه وكان نيجاتيف. Based on the above investigations, she was mostly treated as some sort of chest infection. This is my guess. ان هي دخلت العنايه، طب خدت ايه؟ ما تمام. She was treated as some sort of chest infection and was given nebulized bronchodilators, antibiotics, and a few days for a few days and then discharged while still more or less short of breath and remained so at home for about 2 months. During these 2 months, she sought medical advice several times, received different inhalers, whether bronchodilator or ICS, and has the recent echo revealing ejection fraction 63. Other doctors have some doubt in the echo and in her dyspnea and repeated her echo, ejection fraction 63, pulmonary systolic pressure 45, grade 1 diastolic dysfunction. At this point, we will be responsible for the case. She was short of breath, grade 3, orthopnic, temperature 37, blood pressure 110/70, pulse 105, auto saturation 91, chest examination shows only tachypnea, respiratory rate 26, air entry was good and there was no added sound apart from occasional rhonchi, heart examination was normal apart from mild tachycardia, no tenderness or swelling in her lower limbs. What is the next step, putting in mind the real circumstances in our medical practice? In reality, she was given a dose of enoxaparin and a CTBA was done showing the following. It is a case of pulmonary embolism. I think it is more or less a confusing case, but if we follow more science and if we follow more the, say, guideline, but not doing what we see as logic, it can be diagnosed earlier than at that time. Clinical prediction rule for pulmonary embolism. لو احنا حطيناها من الاول خالص، رحنا حطيناها على الويلز سكور. يعني لو هي اول ما جت للناس حطوها على الويلز سكور، يا ترى الشكل كان هيتغير؟ ده يعني النقطه اللي في الحاله. يعني مثلا previous pulmonary embolism or DVT، لو على original version 1.5 ادي 1.5، الهارت ريت اكتر من 100 ادي 1.5 تاني ادي 3، alternative diagnosis less likely ادي 6. يعني لو حطيناها على الويلز سكور هتطلع اكتر من يعني هتطلع على الاقل خالص انترميديت مثلا. تمام. كلينيكال يعني طالعه بالنسبه للاوريجينال 6، وبالنسبه للسمبليفايد البريفيوس هياخد 1 والهارت ريت هتاخد 1 ادي 2، ويبقى كده برضه ايه بالمونري امبوليزم لايكلي. يعني نحطها على الويلز سكور لازم هتكونسيدر البالمونري امبوليزم. المشكله ان هو اعتمد على الدي دايمر. انا شايف برضو ان حتى الجايد لاين if not supported by some sort of thinking and mental exercise هتبقى بصراحه disastrous. يعني مثلا انا اعتقد ان التفكير في الحاله ديت، واساتذتي ممكن يصلحوا لي، هو ايه اللي يخليها دي ساتوريتد مع نورمال شيست اكس راي، مع نورمال ايكو regarding left side of the heart، مع mild pulmonary hypertension، ايه اللي يوصل حد لجريد 3 ديسنيا مع دي ساتوريشن مع نورمال اكس راي، يعني مع باست هيستوري اوف دي في تي. يعني اعتقد الايفيدنس بتاعها كان جامد جدا جدا. لكن التيك هوم مسج من الحاله دي ازاي هو اعتمد على دي دايمر ونسي كل الساينس وبدا يعالج على الدي دايمر وان النيجاتيف دوبلر، وهي دي كانت الميستيك اللي في الحاله. ده كورنيشن مانيا اللي انا ما اعرفش الناس مش عايزه تزهق منه، وانا ما بزهقش منه بصراحه. انا جايب حاله تاني بصراحه. الحاله دي انا مش يعني هكون صادق مع حضراتكم، انا رسمتها انا حاسس ان عايز. طبعا الحاله الاولانيه هي ريال كيس طبعا، تمام. الحاله دي رسمه تخيليه شويه. ده مستر هيثم ده 21 year old medical student. He is non-smoker. He is from Albania and he is in his first day in his summer vacation in Alex. كان ضيف على الدكتور نادر هناك. Suddenly he felt some shortness of breath and some chest tightness. Although he has no pleuritic chest pain, no hemoptysis, no leg swelling, he is still very concerned he may have pulmonary embolism. مذاكر جديد بقى وبتاع وقاعد يذاكر فدماغه شتت يعني شويه. There is no past history of lung disease and no past history of DVT. Examination بتاعه he appears anxious and distressed and tachypnic, pulse rate 95, temperature 37, blood pressure 130/80, respiratory rate 27, saturation 96. Chest examination unremarkable. There are no clinical signs of DVT. Chest X-rays reveals no abnormality. يعني شاب صغير ما عندوش اي مشكله خالص، فجاه جاله ضيقه نفس. على فكره الحالات دي يعني انا فاكر وانا في جامعه اسيوط، وكان مجند، وفجاه كده هو رجع البيت، قاعد والدته محضره له الاكل وفرحانين بيه ان هو رجع، وفجاه نفسه راح. جابوه على المستشفى، وكانت حاله يعني من الحالات الجميله يعني، لان هو مسافر سفريه طويله، كان الجيش بتاعه في مرسى مطروح، واول ما رجع وقعد وده مجند فجاه نفسه اتضايق، فجاه راح على المستشفى، وبعد كده اتعمل له الورك اب. طيب الارتيريال بلاد جاز بتاعه كان بي اتش 7.53 and HCO3 24, CO2 21, BO2 80 mm mercury, and routine labs were unremarkable, no abnormality. This is ABG. يعني الدكاترة بقى طبعا زي ما احنا للاسف الشديد بعض الدكاتره متعودين، انت يا ابني ما كل ما تذاكر حاجه تفتكرها عندك، يعني اكسجينك كويس واشعاعاتك وتحاليلك كويسه كلها سليمه، لسه مصمم على قصه الجلطه دي. هدي نفسك كده وهدي نفسك ويلا بسرعه على البلاج، انت عندك حاجه اسمها بانيك اتاك and so on. ايه الراي في الكلام دوت؟ اكيد الراي هيبقى مبني على ساينس. واعتقد ان بصراحه احنا مشكلتنا في الميديكال براكتس مش الالات ولا الادوات، مشكلتنا ساعات ignoring الساينس. What is the acid base disorder in this patient؟ تعالى نرجع تاني كده على الاي بي جي. هو عنده الكالوزيس محترم، السي او 2 بتاعه قليل 21، والاتش سي او 3 بتاعته نورمال، يعني هو respiratory alkalosis which is uncompensated respiratory alkalosis. ده بالنسبه للاسيد بيز. طب يا ترى الاكسجينيشن بتاعه اخباره ايه؟ تعالى نرجع، لو رجعنا تاني هنلاقي الاكسجين تنشن بتاعه 80. طب ما ده كويس قوي وممتاز اهو. لا والله مش ممتاز قوي يعني. لما نيجي نشوف بقى ايه دي one of the clinical situations where calculation of the alveolar arterial oxygen gradient can be helpful. لما الاقي normal او near normal oxygen despite CO2 wash، المفروض ال CO2 wash by law هيبتدي يعلي الالفيولار جريدينت، يعلي الالفيولار اوكسجين، تمام، بينما الارتيريال اوكسجين بيبقى قليل. يعني ادي الرول موجود اهو، اللي هو موجود اهو. المفروض ان السي او 2 لما يقل الالفيولار اوكسجين يزيد، وبالتالي الالفيولار ارتيريال اوكسجين جريدينت هيزيد. حسبناها هنا الالفيولار ارتيريال اوكسجين جريدينت طلع 45. هو طبعا في كذا سمبليفايد ميثود تو كالكوليت الالفيولار ارتيريال اوكسجين جريدينت. الايج على 4 زائد 4 مثلا، يعني الولد ده عنده 20 سنه، على 4 يبقى 5 زائد 4 يبقى 9، هو 45. يعني he is actually have oxygenation defect, but when looking to saturation we will find it 96. When looking to tension it is 80. Then he has oxygenation defect by the alveolar arterial oxygen gradient. يبقى الواحد ما يتخدعش في قصه ان الساتوريشن كويس والتنشن كويس، خصوصا لما يلاقي السي او 2 واطي. السي او 2 واطي المفروض الاكسجين يعلى، المفروض الارتيريال اوكسجين تنشن يعلى. وحضراتكم بنشوفها كتير في البانيك اتاكس، فعلا البانيك اتاكس الحقيقيه تلاقي الاكسجين 110، حاجات زي كده، والناس تستغرب طب هو على اكسجين؟ لا ده مش على اكسجين، ده على روم اير، بس هو تكبنك وعامل سي او 2 ووش and so on. What is the likely diagnosis? Given the recent long distance travel, absence of clinical and chest X-ray abnormalities, the most likely cause of breathlessness and impaired oxygenation is pulmonary embolism, and he must be investigated at least accordingly. والله يطلع نيجاتيف مش ما خسرناش حاجه يعني، بس يبقى investigated for that. a more simple way. بصراحه الطريقه دي انا دايما انا مش لاقي جونيور دكتورز بصراحه، لكن الجونيور دكتورز واحنا في الاستقبال كده او لو انا على التليفون ان انا اقول له ويلز سكور ونسمع مع بعض الويلز سكور، انا شايفها شويه طف يعني. ففي حاجه موجوده في البريتش ثوراسيك سايتي بري تيست كلينيكال بروبابيلتي، طريقه بسيطه قوي على الاقل قبل الويلز سكور، بعد كده نبقى نطبق الويلز مش مشكله يعني. ان احنا لما يجي لنا حد عنده شورتنس اوف بريس وذر ويزاوت هيموبسيس وذر ويزاوت تشيست بين، هنشيك 2 بوينتس: presence of risk factor for pulmonary embolism دي نمره واحد، وabsence of other reasonable explanation for shortness of breath. لو if A and B ده high pre-test clinical probability, if A or B intermediate probability, if neither A nor B it is low probability. يعني لما يجيني حد short of breath ومش لاقي له سبب ادور على risk factor for pulmonary embolism. لو عنده risk factor for pulmonary embolism I have to take this into account. ده كورنيشن المنيا المختلف المظاهر هو احسن حاجه في المنيا. دي ثالث بروبلم سولفنج. البريشر انا لغايه ما يخلص الوقت انا شغال يعني. ذا بريشر الارم اوف ذا فنتليتور. اتفضل. ماشي يا فندم. البريشر الارم اوف ذا فنتليتور سيرفينج اي ار ديس بيشنت از رينجينج. patient is on Sime V, tidal volume 7 ml per kg, beep 12, pressure support 10, FiO2 50. You are asked by the resident to help decision making. Peak pressure is 45 and plateau pressure is 26. البريشر الارم قاعد يضرب، عنده اي ار دي اس، البيك بريشر بتاعه 45 والبلاتو 26. يا ترى ايه السبب؟ ممكن يكون بروجريشن اوف ذا ار دي اس، ولا نيموثوركس، ولا سكريشن اوبستراكتنج، ولا اير واي سبازم، ولا 3 و4، ولا بالمونري امبوليزم، ولا نون اوف ذا اباف. طبعا هي القصه معتمده، اخد نص دقيقه تاني. هي القصه معتمده على حاجه واحده بس، ان البيك بريشر عالي بينما البلاتو ستيل وزن نورمال. لما البيك بريشر هو اللي يعلى والبلاتو نورمال، دي قصه في الاير واي او في الريزيستنس بمعنى اصح. فهي القصه كانت الاسبازم والسكريشن. الاسبازم والسكريشن هم اللي عاملين المشكله. طبعا اكيد ان الكلينيكال بتاع العيان اهم، لكن هي كبروبلم سولفنج ميكانيكال فنتيليشن هي بالشكل دوت يعني، ومشكل خالص. السلام عليكم.
Thank you very much, Dr. Nazar. The next speaker will be from Yemen, Dr. Abdelkader Bayazid. Sonographic presentation in chest diseases.
First of all, I would like to thank the organizing committee for giving me the honor to be here with you. Thank you very much. Okay. I would like to talk about thoracic and transabdominal sonographic finding in patients with dengue fever, dengue hemorrhagic fever. Dengue hemorrhagic fever is the most rapidly mosquito-transmitted infection in the world, caused by one of the 4 viruses belonging to the family flavivirus. In the last 50 years, incidence has increased by 3-fold, increasing the geographic expansion to a new countries in the present decade. In the present decade, from urban to rural areas, an estimated 50 million people has dengue fever annually, and about 2.5 billion people live in dengue endemic countries. World Health Assembly in 2005 included dengue fever as an example of a disease that may constitute a public health emergency of international concern with implication of health security due to the disruption and rapid epidemic spread beyond these national borders. The outbreaks of dengue fever documented in the Eastern Mediterranean region, possibly as early as 1799 in Egypt. The frequency reported outbreaks continue to increase, with recent outbreaks suspected dengue have recorded in Pakistan, Saudi Arabia, Sudan, and Yemen. This is also affected by the increasing frequency of geographic spread epidemic dengue, and the number of cases is rising since the major dengue epidemic that occurred in western Al-Hudaydah, a Yemeni governorate in the west of Yemen in 2005. In 2008, dengue affected the southern province of Yemen. Before about 20 years, we didn't hear about dengue fever in Yemen at all. But now we have a lot of epidemics since the year 2005. No vaccine is present available for dengue fever. Dengue fever is present with frontal headache and myalgia, joint pain, muscle pain, fever, and nausea, vomiting. Serology is the mainstay in the diagnosis of dengue hemorrhagic fever. However, hemagglutination inhibition antibodies, immunoglobulin G and immunoglobulin M, takes about 7 to 10 days to become positive. So we have an urgent need for an early tool to diagnose dengue fever in the early days. This study was conducted with the aim to evaluate the sonographic findings in dengue hemorrhagic fever patients in our locales and to determine the use of ultrasound as an important adjunct to clinical and laboratory profiling. To our knowledge, no published study described this finding in our region at that time, in 2010. We include about 70 patients with dengue fever, came from areas with epidemic, came with the clinical presentation of dengue fever. Then after the serology was positive in 50 patients, 20 of them were excluded. So we have 50 patients with serology positive dengue fever were subjected to ultrasonic examination, thoracic and abdominal. The results, among 50 patients with positive serology test for dengue hemorrhagic fever, males and were 68 and 32 were females of them, with the peak of 22 years old in this study. These are the presentations that happens usually in dengue fever and in our patient. And here, regarding the sonographic finding that we found, a thickened gallbladder, it's usually the thickening of the layers of the gallbladder, anterior part of the gallbladder, about 4 millimeter. We found it more than 15 millimeter. We found pleural effusion, mainly right-sided and bilateral, and we find ascites in our patient. This pleural effusion, and here we have the gallbladder and ascites. So ultrasonic finding, gallbladder pressure we found in 98%, for 49 patients out of 50 patients have gallbladder thickening. Pleural effusion right side we have in 41 patients out of 50 patients. Left pleural effusion only in 1 patient, bilateral effusion in 5 patients, and we find ascites in 91% of patients, hepatosplenomegaly in 70 and 11% accordingly. Pericardial effusion only in 1 patient we found, and pancreatic enlargement we found in 2 patients out of 50 patients. The diagnosis of dengue fever is made in the basis of clinical presentation and laboratory results, which can be confirmed by serologic detection of the virus itself or antiviral antibodies. But results are often obtained too late to be of clinical benefit. Therefore, an additional diagnostic tool for the use of evaluation patients with suspected dengue hemorrhagic fever are being sought. Although specific, the sonographic finding, although non-specific, the sonographic finding in dengue hemorrhagic fever are obtained more rapidly than the results of serology test. The most common sonographic finding in the patient is with milder dengue hemorrhagic fever are thickened gallbladder pressure, gallbladder wall, and minimal ascites, pleural effusions, and hepatosplenomegaly. Severe forms of the disease are associated with a collection of fluid in the peri and pararenal regions, hepatic and splenic subcapsular, and pericardial effusion, pancreatic enlargement, and hepatosplenomegaly. The gallbladder thickening wall was combined with right upper quadrant pain, and differential diagnosis includes acute acalcular cholecystitis. Gallbladder wall thickening is also occur in association with other conditions such as acute hepatitis, heart failure, renal failure, liver cirrhosis, hypoalbuminemia, non-fasting status with contracted lumen, and therefore a major limitation of the study. Imaging features of dengue hemorrhagic failure, such as gallbladder thickening, ascites pleural effusion, hepatosplenomegaly, and are reasonably accurate, and they are early diagnosis. In the early diagnosis of dengue hemorrhagic fever, helps in starting appropriate measurements in patient as soon as ultrasound is done, especially in centers where high level of laboratory facilities may not be available for serological manifestation, as the situation in some provinces in our country, in Yemen. Later on, this study had been conducted in 2010, and later on we have similar studies done in several countries. Sayyid al-Jum'i saw significant association with thickening gallbladder and the severity of dengue fever and other pleural effusion ascites. Santo reported the severity of course in the disease directly linked to platelet count. In our series, we found hepatosplenomegaly was also frequent sonographic finding in addition to the gallbladder thickening, the pleural effusion and ascites. Thus, results are similar to those results observed in other epidemic areas in dengue fever. In an area experiencing dengue hemorrhagic fever epidemic, when sonography shows a thickened gallbladder, ascites, hepatosplenomegaly, and right pleural effusion in a febrile patient with thrombocytopenia, dengue hemorrhagic fever should be considered. In the differential diagnosis, treatment can be started before serology tests were positive. And this is an algorithm suggested by Sanotit in patients presenting with features of dengue fever. Ultrasound examination should be done. If it shows features of gallbladder thickening, ascites, and pleural effusion, hepatosplenomegaly, this patient have more chances to have, and the patient have thrombocytopenia. We have to start early treatment of dengue fever. What we conclude of our study, that sonographic features with a thickened gallbladder, pleural effusion, bilateral or right-sided mainly, ascites, hepatosplenomegaly, and should strongly favor the diagnosis of dengue hemorrhagic fever. Transabdominal thoracic sonography can be used as adjunct first imaging modality in patients with suspected dengue fever to detect early signs suggestive of the disease prior obtaining a serologic diagnosis. Simple ultrasound examination will effectively expedite the diagnosis and justify initiation of specific treatment for dengue fever. Gallbladder thickening, ascites, pleural effusion were found in the most common combination sonographic finding in all of our groups. And thank you very much for listening.
Thank you very much for your presentation. Is there any question for the speaker from the audience? We have time for 1 to 2 questions. Okay, if not, we shift to the next speaker, Professor Omar El-Haj from Sudan. He will give Sudanese case presentation. Professor Omar.
Thank you very much, Mr. Chairman. And I would like to thank the organizing committee for giving me this opportunity to deliver my talk, Professor Jamal Ajami and his team. My case presentation, the objective of this presentation is to reinforce and highlight common concepts, situations, and presentations that clinician will encounter on a regular basis in our setting in Sudan, in Khartoum. A 23-year-old Sudanese woman presented to the ER with a 1 week history of nausea, vomiting, diarrhea, and lower abdominal pain and hallucination. She has 5 children, all of them were normal vaginal deliveries and were born healthy. She has a 1 year history of irregularity in the menis and dysmenorrhea. She is not a smoker and is not taking any medications on the regular basis. Her family history is unremarkable. On physical examination, the patient appeared toxic, confused. Her oral temperature is 39.8. Her pulse is regular with a rate of 50 beats per minute. Her blood pressure is 110/60. She is noted to have generalized pallor, but no clubbing, jaundice, or cyanosis. Abdominal examination reveals distension with mild generalized tenderness, hepatosplenomegaly. There is a mild to moderate amount of ascites. The chest examination, there is a bilateral coarse crackles, and the remainder of the physical examination is unremarkable. And we put our differential diagnosis according to our setting. First, ARDS, left heart failure, abdominal malignancy, severe malaria, visceral leishmaniasis, lymphoma, and abdominal tuberculosis. We started to investigate her according to the differential diagnosis, putting in our mind that our country is endemic of malaria, blood film, and ICT for malaria negative. For the abdominal tuberculosis, MAN2 test is negative, and the sputum for acid fast bacilli negative, PCR for TB negative. Echocardiogram is normal, and the CBC revealed normochromic normocytic anemia with a hemoglobin of 9 gram per deciliter and high ESR of 50. The urea is a bit high, 75, and creatinine is 1.6, and the potassium is low. These are liver function tests. The total protein is low, albumin is low, and there is a high ALT and AST. The rapid test for HIV was negative. The liver and renal function, as we saw, that impaired with the high urea, creatinine, and the urine analysis is positive for red blood cells and white cells and protein. The chest X-ray, these are chest X-ray, which shows bilateral patchy consolidation. And this is our CT scan. Also, there is a bilateral patchy consolidation. This is a lung window. And this is the report came from the X-ray department. There the view is bilateral patchy consolidation and nodular masses involving the whole lung. He put the differential diagnosis of metastasis, and he said for evaluation, biopsy is advised. A CT abdomen, CT brain is normal. This is CT brain because she has hallucination and confused this CT brain, which is absolutely normal. Ultrasound of the abdomen and pelvis demonstrate ascites. And this is ascites. With peritoneal deposits and moderate ascites, found a sample of acidic fluid were sent for analysis, which revealed an exudative ascites with a predominance of neutrophils, which is 80%. No organism is found on culture or gram stain. And no malignant cells are noted on cytology. The CT scan of the abdomen and pelvis performed, which confirm the presence of moderate ascites and liver and spleen nodularity. There is a nodule in the liver and in the spleen. Also, there is a multiple nodule in the liver and in the spleen. The carcinoembryonic antigen level are found to be within the normal. Alpha fetoprotein also normal. ANA was negative. And as we know that also in our country there is endemic area of enteric fever, we said to test for enterica. And the Salmonella typhi is 1/20, and the para-TB is 1/80. And fetal test for Salmonella was positive, and blood culture was positive for Salmonella. And the final diagnosis of our case is enteric fever. And we started her on levofloxacin, 5 milligram BD infusion, and azithromycin capsules, 500 milligram once per day for 10 days. And these are X-ray after treatment, and these are CT scan after treatment, and this is our investigation, CBC and urea and liver function after treatment, which come to normal. Okay. Typhoid fever are prevalent in many countries in the world, and this is the area where is in the green the endemic, high endemic areas. Enteric fever is a syndrome associated with severe few of Salmonella. There is two types of Salmonella, Salmonella typhi and Salmonella para-TB. And the para-TB is A, B, and C. Typhoid fever is a bacterial disease caused by Salmonella typhi. It's transmitted through the ingestion of food and drink contaminated feces and urine. And para-TB fever are produced by other species named A, B, and C. The bacteriology of the typhoid fever, the genus is Salmonella, belong to the Enterobacteriaceae. It is a facultative anaerobe gram-negative bacilli, distinguished from other bacteria by a biochemical and antigen culture. There is two types of antigen. And the paratyphoid fever rise by fever and caused by the any of three serotype A, B, and C. How typhoid fever is spread? Salmonella typhi live only in human. Person with typhoid fever carry the bacteria in his bloodstream and intestinal tract, and then he distributed the bacteria. The clinical feature of typhoid fever, first, patient presented with septicemia, fever, bradycardia, splenomegaly, abdominal symptoms, rose spots, which is a characteristic of Salmonella, complications such as intestinal hemorrhage, perforation, and if there is any delay of treatment. Fever, all the events coincide with fever and other signs of clinical illness. From gallbladder, further in variation occur in ingestion. Ingestion to onset fever varies 3 to 50 days, 2 weeks. Insidious started. Early symptoms are vague, dull, continuous headache, abdominal tenderness, discomfort, may present with constipation. Temperature fall by crisis in 3 to 4 days. Complications, severe intestinal hemorrhage and intestinal perforation. If not diagnosed, can lead to fatal complication. There is a relapse of the disease, and this is the immune response first by the IgM and IgG. Morbidity and mortality, if untreated, the mortality reach up to 20%. The diagnosis by blood culture in the typhoid fever. In adult, there is 5 to 10 ml of blood is collected by venipuncture and then sent to the lab for diagnosis. And this is the culture of bacteria. The identification of salmonella, subcultures are done after overnight, incubation at 37 degree, and subcultures are done on MAC conky agar. And this is a culture of the salmonella. Other methods of the isolation from the feces, from the urine, and from the bone marrow culture. The diagnosis of enteric fever by a Vidal test. The antimicrobial, as we said that, first they treated this enteric fever by chloramphenicol, but nowadays by levofloxacin and macrolide. This is our reference. And finally, I would like to invite you to attend our 10th scientific conference, which will be held in Khartoum in the date of 3rd and 4th April 2016. And thank you very much.
Thank you Professor عمر الحاج for this nice presentation. يعني بس في دكتور أمجد تساؤل. اتفضل دكتور أمجد. دكتور أمجد فرحات. دكتور عمر
please.
You
have 2 questions, please. Okay. You have presented a very, very nice case for typhoid pneumonia or bronchopneumonia, but I have 2 questions.
Okay.
How long does it take the blood culture for typhoid? You performed for this case Vidal Brucella and blood culture, yes?
Yeah.
How long does it take?
It takes 10 days to 2 weeks.
And you waited for this patient 10 days?
No. We started him on levofloxacin, and when we started to rule out the HIV and tuberculosis and malaria and other causes of this condition in our setting, and we start treatment of enteric fever by a Vidal test, which is a repeat test. We don't wait to the culture, but we started on the basis of the Vidal test, which is positive.
The second question, you used the combination of levofloxacin and azithromycin.
Yeah.
And this combination covers most of the pathogens in the lung. How can be sure that the organism was typhoid?
No, we culture the organism, and the culture of enterica is positive after 2 weeks.
I'm talking about the sputum, not the blood culture. It was positive for typhoid?
No, not only the sputum. The sputum culture is negative for no organism in the sputum.
Okay, thank you very much.
Thank you very much, Dr. Omar. Now come to the last speaker, Dr. Islam Ibrahim from Saudi Arabia.
Sure. Bismillahirrahmanirrahim. Good morning. I'm known to be a little non-orthodox in my presentations, and I'm going to take you through an unusual pattern of presentation. First, I'll let you know about the clinical picture of the patient, and then I'll tease you out for what you want to do next. This is a 31-year-old male patient, works in construction. His past medical history is only positive for asthma. And as you will see, 2 years, the patient has been struggling with his asthma control. He presents a lot to his physician's office, emergency departments, with asthma flares. He scores very poorly on asthma control tests. He had been on multiple courses of antibiotics and steroids. His current medications include Symbicort, albuterol, and multivitamins. So he comes again complaining of recurrent cough, wheezing, and he tells his physician that when I cough, there are these thick brownish plugs of mucus that come out. And he also reports subjective fever on and off at home. On physical examination, the only finding is some expiratory rhonchi, best heard at the upper part of the chest. The rest of the physical examination is unremarkable. Initial laboratory tests, notable for significant peripheral blood eosinophilia. As you can see, LDH is elevated. The rest of his chemistry and liver functions are within normal limits. I will show you his chest x-rays 2 months earlier and at the time of presentation. And I'll guide you through the findings. As you can see on this chest x-ray done 2 months earlier, there is some hazy infiltrate involving the right lower lobe, mostly in a central location, and you can appreciate some nodularity as well. There is also a little bit of infiltrate in the left lower lobe as well, and some nodularity. And you notice this density or shadow in the right upper lobe. In the current chest x-ray, you see that the infiltrate is still in the right lower lobe, but probably moved a little peripherally from this location to this location. You would also appreciate some reticular nodular pattern, some haziness in left lower lobe, and this shadow in the right upper lobe is increasing and is becoming denser. And I will leave you there. The patient is now sitting in front of you, and I have a bunch of investigations, but I'm not going to tell you what I did, and I'm going to ask you, what would you like to do next? And depending on your choices, I will select a slide that represents it. So what would you like to do next? Okay, what is the name of the test? Right away, Aspergillus, specific IgE? Okay. Okay, very good. Well, this is a very good audience, and obviously the case is related to the topic that I gave a couple of days ago. But okay, let me take you with a very simple thing initially, show you, as any clinician would do, we'll get a CT, and I'll take you over the sputum, because I think there is a good finding on the sputum sample that I'd like to draw your attention to. Who can tell me what you see on the sputum sample? The name of these little crystals? Exactly, charcoal laden, which indicates that we are dealing with some sort of allergic disease, because this is the breakdown of eosinophils. So helminthic disease, parasites, any allergic disease in the lung will give you that finding. It's not specific, but you also see something here in the background, a little hazy rods that I will come back to. Let's go back to the CAT scan and see what we see on the CT of the chest. In this particular cut, and obviously the arrows are pointing out to areas of densities, let's call them, and within the densities you see these bronchiectatic changes. And this is an area of consolidation and most likely mucus impaction. Who wants to do pulmonary functions?
Any takers for pulmonary functions in this patient? Well, he's asthmatic after all. He's already asthmatic. Don't you want to do like a follow-up to see if his pulmonary function is getting worse, getting better? No? Okay, not a priority. Who wants to do a bronchoscopy? You want to do a bronchoscopy? Okay, let me find you bronchoscopy slide. This is what you got from the airways after bronchoscopy BAL. The airway had lots of plugs, difficult to remove with a fiber optic bronchoscope. And what you see here is, again, the findings of the same crystals and lots of eosinophilic infiltrate. You're probably not able to distinguish other structures on this slide. But during the bronchoscopy, the patient desaturated because of the those plugs were moving from one bronchus to the other. And then they decided to go ahead and remove some of those plugging mucus of the airways. And that's what it looked like. So am I convincing you now we have mucoid impaction in these dilated bronchiectatic airways? Okay, so back to the audience in the back. I'm sorry? Exactly, aplastic bronchitis, absolutely. Now let's see what else we have. So pulmonary function test was not a priority. Do you want to measure anything else on the serum or while we have the bronchoscope in the patient? We had these plugs, we have BAL. Do you want to test it for anything? True. I'm still in the bronchoscopy suite though. Do you want to use the BAL or the broncho wash for any other testing? Okay. Okay, great. So cultures were negative. And okay, looking for aspergillus. Okay, I'll come back to that. How about running a galactomannan? Okay, very good. So I have a slide here for the galactomannan, slide number 12, which was normal. Does that make you less convinced that you're dealing with aspergillus when galactomannan is negative? So now you're thinking of a different fungus, not aspergillus per se. Okay. So who wants to do a serum galactomannan? Anyone? Well, it was done in the patient. Serum galactomannan was normal, and the BAL galactomannan was also normal. Oh, I showed you the serum first. Okay, but the BAL galactomannan was also negative. Now, how convinced are you at this point that you're dealing with aspergillus? With a negative serum galactomannan and a negative BAL galactomannan? The patient had been on multiple courses of steroids, but currently was not taking steroids. Okay, sure. And then we're trying to find out this hypersensitivity is secondary to what? Obviously, he's a construction worker, so he could be exposed to some significant dust, pneumoconiosis, but he's also young, he's only 30. Absolutely. So we'll go to IgE, slide number 14. Total serum IgE level is 5,765. It looks like the doctor had hit the jackpot. So what's the diagnosis now? Allergic bronchopulmonary aspergillosis. How would you confirm that? Okay, so someone is asking for a skin test, Dr. Rabia. So we'll go to slide number 11. And the patient had a positive immediate hypersensitivity reaction to Aspergillus fumigatus. Are you satisfied? Do we have a diagnosis at this point? Do you want anything else? Do you want any other confirmatory tests? Oh, the specific IgE and IgG. Okay, we have that on slide number 15. Let's see what we have. Strongly positive precipitating antibodies, both IgG and IgE. So I think now we have all the criteria fulfilled for making a diagnosis of ABPA. You agree? Okay. I want to take you back to the sputum because that's a point that I wanted to make. Now, we have seen the charcoal-laden crystals, but the one thing that was in the background and so hazy, that is aspergillus. But you will tell me that the way you presented aspergillus was an acute angle 45-degree branching hyphae that tested positive with silver stains and stuff. Yes, but when you look at in the sputum, it appears differently, and it doesn't have the classic appearance. And I guess that's the point that I'm trying to make, is if you did a KOH prep on that sputum, it'll probably test positive for fungal elements. And in this particular case, the fungus is here. These are septated hyphae, classic for the aspergillus and fusarium. But you don't see the classic appearance of aspergillus as you would see on a silver stain from a BAL or a biopsy. So let me move to slide number 16. The next step in managing the patient's asthma is to do what? Option number one, he had not been on steroids for a while, so I can bump up his dose to 40 milligrams for 1 month and then taper down slowly. Number two, the skin test, we already did that, so we diagnosed him. Serum galactomannan, done. IgE level, done. Fiber optic bronchoscopy and BL galactomannan, all done. So, if you were investigating the patient without knowing everything we talked about, would you have chosen serum galactomannan and BL galactomannan? I think that is the point of the slide. The answer is, serum galactomannan in this case was negative, but the patient does have ABPA. BAL galactomannan was negative, while the patient has a fungus and an allergic reaction. And the simple answer is, you expect those to rise in the invasive form of aspergillus. Only when aspergillus is invading the tissue that you find these particles of the cell wall in your BAL, in your biopsy, and in your serum. So ABPA cannot be diagnosed with galactomannan. Only invasive forms of aspergillus are pertinent to that type of test. So would you agree we need to increase the steroid dose for this patient? Do you agree with 40 milligrams of prednisone? And do you agree with the duration? Okay, this will become apparent as we talk a little bit about aspergillus and ABPA. So what is allergic bronchopulmonary aspergillosis? Obviously, some predisposed individuals, because they have a certain HLA type, or more likely cystic fibrosis, patients with asthma, patients who are not able to deal with the fungus in an ideal way, and they have a hyperreactive immune response to the fungus. And this is because of the imbalance between the maturation of T helper 1 and T helper 2 cells. The predominance in this disease is maturation of 2 helper type 2 in certain individuals. I presented that slide in my talk a couple of days ago. What happens is the fungus is in the airway, these conidia are inhaled, and then the fungus wants to grow. So it starts to spread the hyphae. These hyphae in the middle, which are classic appearance of aspergillus, branching at an acute angle 45 degrees, staining positive with silver stains, GOM. And this is what you would see on a biopsy, if you took a biopsy, intense inflammatory reaction. And if you find the fungus, that's invasive disease. You don't find the fungus, it's ABPA. Now, I would like also to point out that the immune response to aspergillus is 2 different types. One is an immediate reaction, and one is a delayed response. The immediate reaction, patient is in the lab, you prick the skin, you expect the reaction within 5 to 20 minutes. So that's the immediate type that depends on the degranulation of mast cells, mediated through IgE. That's why IgE is elevated more than 1,000 in these patients. Now, there's also a delayed type of hyperreactivity by the formation of antibody complexes and activation of the complement system. So you would expect 4 to 8 hours after the test, the patient could develop induration at the site of the test. So the immediate skin reaction is positive, with a possibility also of a delayed reaction. Can I have 1 minute? Just a couple slides. Can I have just 1 minute? Just a couple of words on the treatment, since I mentioned that on the slide. Treatment has to be a combination of steroids plus an antifungal. Amphotericin had been tried, itraconazole had been tried, voriconazole had been tried. The most successful regimen now is a combination of steroids and itraconazole for a period of 3 months. That's why the answer of continuing for 1 month and then tapering down was wrong. So you need to continue for 3 months. The antifungal therapy can extend from 3 to 6 months and then titrating down over an extra 4 months. So the treatment is very close to 10 months to a year. Okay. Are you sure? Okay, I had a couple other slides, but افتح كده صح؟ ايوه ايوه ثانية واحدة ايوه. And oh, okay, yes. So I was going to go through the criteria. This patient came to us with a picture highly suggestive of ABPA, and the point to take home is when an asthmatic patient is poorly controlled and presenting with recurrent fleet and infiltrates on the chest X-ray, and you find evidence of eosinophilia, means that's an allergic disease, and mucoid impaction like that, you need to think about ABPA and do exactly what we did with this case, the skin prick test, the IgA level measurements, and the precipitine tests. Now, this is the criteria. These 5 elements on the left, you absolutely need to make a diagnosis. So you need the patient to have these asthma symptoms, to have the positive prick skin test, to have the elevated IgE level, and to have the specific IgE and IgG precipitine antibodies. If you don't see the central bronchiectasis at that point, you can call that seropositive ABPA. If you have the bronchiectasis, you have the full picture. Those 2 things on the right-hand side, the infiltrates and the eosinophilia in the serum, are not mandatory to make a diagnosis. This is the slide that I wanted to show at the end, which explains the treatment, 3 months as we said, and this is the slide that I wanted to show from last night. Thank you so much. كل عام وانتم بخير وطيبين.
Thank you very much, Professor Islam Ibrahim, for your elegant way of case presentation. And we are closing now this session, but please remain seated. The next session is very strong. This is a pediatric session and very eminent speakers. And may I call the chairpersons of the next session, Professor Ahmed